Good morning, good afternoon, those of you who are with us on the other side of the world. Welcome back to the seventh edition for VUMI Health Talks. Today, we will be addressing the topic about address transplant organs. We believe this is a very important topic, a part which is really interesting for you. Next, please. Okay, thank you so much. As you all know, this is the seventh edition and the seventh lecture. The lectures will be will be conducted in Spanish with simultaneous translation into English and Portuguese when you consider it necessary, depending on the language you are more comfortable, and we will be providing the instructions. In your meetings control, click interpretation. In the border part of the screen, you will find a globe that has, it's a globe icon that you will choose interpretation. You can, as a default, it's in the Spanish channel, but you can also choose not only the English, but also the Portuguese in case it is necessary. So it is important for you to consider that you need to join to the if you're doing it through the dial-in, which is the number phone that you have from the sessions, but in the phone call, you won't have access. So you won't, you will have this available in a desktop or laptop, depending on where you are connected right now. This is how you can listen to the interpretation mode. Well, apart from this, you will find also in the lower part of your Zoom, you will have a Q&A session, the Q&A chat. As many of you who have participated for in all sessions, you can send your questions in the Q&A chat for our speaker, Dr. Jairo Rivera, and we will be translating these questions at the end. You can run any time of the lecture, but at the end of the section, we will have the Q&A. Please do not use the Zoom chat to make your questions. Well, some of you may know me by now. I'm Dr. Miguel Guavil. Currently, I'm the Telemedicine and Health Programs Manager at VUMI. I have experience in the field of digital health and implementation of technological data and projects. This is the seventh time I'm here with you in this VUMI talk. So I want to introduce now to Dr. Carolina Saavedra Perez. She is our representative of our partner with Sura. She's a specialist in health services management. She has more than 20 years of experience in the health sector, in all the administrative management and leadership of high performance teams. She has actively participated in the creation, development, and consolidation of strategic projects within Sura, our current partnership. She will be showing us how this partnership has been created between Sura and VUMI, and also to introduce the cardio, who will be our host today in this important topic, which is the organs transplant. Okay, on my part, I will see you again at the end of this lecture. And Carolina, the floor is all yours. Thank you so much for being here. Okay, thank you, Miguel. Welcome all people connected from many parts of the world. It's a pleasure to greet you all in this space and being able to introduce you in strategic partnership, strengthening services in Colombia. VUMI Sura, and this opportunity is joining to offer a comprehensive coverage. Sura is in charge of operating insurance, supported by a robust system, guaranteeing a reliable and timely service. We have the presence in the most important cities, Bogota, Medellin, Cali, and Barranquilla, with our own facilities. And we have more than 1,500 networks around Colombian territories, more than 7,000 specialists and physicians. This allows us to respond to any insurance issue. This alliance not only represents coverage, but also a permanent support, service excellence, technical quality, and a profound medical expertise. Thank you all for being here with us today, and we hope that this space will allow you to know more about how can together we can transform the experience of health in Colombia. Next, please. Now we want to welcome Dr. Jairo Rivera Vaquero. He is an abdominal organ transplant surgeon. Currently leads the pediatric liver transplant program at La Cardio, Fundación Cardio at La Cardio, Fundación Cardio Infantil in Bogota. He has been working as a transplant surgeon at La Cardio since 2008, leading program in Colombia for several years. And he's also vice president of the Colombian Association of Organ Transplantation, member of numerous scientific societies. Doctor, it's a pleasure having you with us today, and go ahead, the floor is all yours. Okay, thank you so much, and good morning to all that are here participating in this lecture. We are really pleased and honored to represent my institution, La Cardio. You will know a little bit more about it later on. Okay, thank you so much for your introduction, Dr. Carolina. We will be talking about the approach and care, the pre and post transplantation care. We will be following this outline for today. I would like for you to make all the questions that are necessary. There are no questions that are not relevant. All the questions are important, so I hope that at the end you will enjoy this lecture. First of all, we will be talking about the definition and history of transplant, not only in the world, but also in Latin America. Some overall information about transplants, indications, and care before transplantation. Care before and after. Some conclusions, and at the end, we will have the Q&A session. It is important for us to know what's a transplant, and in accordance to the WHO, a transplant of organs is defined as a medical surgical procedure by which a diseased or terminally failing organ or tissue will be in a recipient, and this will be replaced by a healthy organ or tissue from a living or deceased donor, with the aim of restoring lost function and improving the patient's survival and quality of life. From transplant, we've been hearing years ago. There are reports from the ancient China, where it's reported that a very known physician, Hua Tuo, did organ transplant with traditional medicine. This clearly has not been proved, but from that time, we have been hearing about the first reports. And you have heard in the 3rd century about the Saints Cosmas and Damian. They were physicians whom they did a transplant of a leg to a patient that was sick. Then a foreign person in the 8th century in India, it started to experiment tissue transplantation, and in the 18th century, experimentation on plants, mollusks, and other animals started. And in the 18th century, it was the time when it was done that first tissue transplantation, specifically in skin. In 1905, the first corneal transplant was done with this. This is a tissue. This is not an organ. The most important topic for our talk. And until 1954, Dr. Joseph Murray performs the first long-term kidney transplant. The first experiments in the transplant were done with animals. And in this way, this was cleared out, the surgical technique, which is relatively the same technique that we are using currently in most of the organs. In 1963, the first liver transplant is performed on behalf of Dr. Thomas Tarsal in the United States. In 1967 in South Africa, and there are some reports in Brazil as well, to have the first transplant performed. But despite the fact that the technical surgical technique was good and the outcomes were bad, these were not positive. Outcomes were not good because of the immunosuppression. This is to reduce all the immune system for the implant that's been done, and they will not have any type of immunological response that will not be attacking the organ. And thanks to the invention of the cyclosporine, the outcomes on a short and long-term basis improved relevantly. In Latin America, we are not so behind, very close to that first kidney transplant. The first one is done in Argentina. In Colombia, we did it in 1965. Brazil also develops the first kidney transplant after this date. And in 1968, the first heart and liver transplant is done in Brazil. In Colombia, in 1979, we have the first report of a liver transplant. Now I want to tell you a little bit of my institution, the institution where I belong, and I hope it will be complying satisfactorily all the health necessities. We are an institution located in Bogota, the capital of Colombia, that was founded in 1963 by two of our founders, a cardiologist and a cardiovascular physician. And our mission has not changed. It's to support and attend low-income children. Slowly, we have become, as an institute, initially we are focusing in cardiovascular patients, but given the need that the country had, and as we have seen in Latin America's need, in 2005, we performed the first transplant. We found the transplant unit and the first adult kidney and heart transplant. Our evolution goes ahead with relevantly on a national basis and also in Latin America. In 2013, we received accreditation by the Joint Commission International, and we are in the third accreditation until now. We also are recognized as a university hospital and research center, and we also have some milestones that have been achieved. Within medical pathologies in 2017, we did the first cardiac transplant cardiac in Latin America. We became in 2019 as the first hospital in Colombia and third in Latin America in accordance to the America's economy. And we performed a brand transformation. Before you heard about us for Fundación Cardio Infantil, and our hospital is known as La Cardio, but we are the same institution. We are one of the institutions that have an important recognition, particularly because we have a program of liver to 1,212 in 2,500 meters of height. This is a milestone. We transplanted all three organs: liver, heart, kidney, lung, and pancreas. To now, we have done more than 2,383 cumulative transplants from 205 to 225. So this makes us become in a very important position. We are the first transplant institution of Colombia, and in some cases, as in the case of liver, we are one of the most important in Latin America. This is my program. Right now, we have been able to transplant more than 400 children, liver transplant, and from this, more than 300 children have been transplanted with living donors. Because for patients that are international and abroad patients, in accordance to the international regulation, the possibility of transplanting an organ can be done for abroad patients and also with living donors. Apart from this, we have the first pediatric excellence center for liver carcinoma, the liver transplant program that has been certificated by the Joint Commission International, already working with an important number of patients. This carcinoma liver is an important disease, and this program is addressed to adult patients. And this is a pioneer program and an excellence program in pediatric liver. And some of the milestones that we have been able to achieve related to our first transplant activity. We did the first pediatric living donor liver transplant in Bogota. We have the first pediatric liver transplant program in Colombia for several years, and we are the largest historical volume of living donors of Colombia, more than 300. We also have the first adult living donor transplant program of 2 adults. We also have more than 100 patients that have been transplanted with this technique. And as I was saying, we are the first pediatric transplant hospital in Colombia. One of the first important projects that are ongoing right now. This year, we started with the first center, excellent center in pediatric liver transplantation, and we are hoping to be certificated with the Joint Commission next year in this scope. What should we do whenever we think about we have a sick organ and we think that eventually we will be needing a transplant, our physician needs a transplant? Well, the first thing we need to know is to perform a complete evaluation to know how and when the transplant should be transplanted and should be done. And this is done by our specialist that will be managing this case. Generally speaking, in the case of heart transplants, this will be done by the cardiac failure program. In the case of liver transplants, will be decided by the liver physicians or hepatologists. And in the case of a kidney, of course, this will be done by nephrologists. They are the ones that they need to know if there is an indication, if there is any other different alternative for the transplant. And of course, during the assessment, we need to know if there's any type of contraindication for that transplant. For a transplant, in order to receive it, we need to have an access to a donor. Many countries in Latin America, especially in Central America, unfortunately, they don't have transplant services or the donor rates is too low. And for this reason, first of all, public policies have to be done in order to increase the donor rate. And also, on the other hand, to look for other alternatives as another donor. Also, it's important to know that, as we have had seen in the previous done by the WHO, an implant means implanting an organ that is not mine. And for this reason, we are going to need immunosuppression, as I told you before, has its main goal that we can tolerate this type of organ in our body. Generally speaking, we have 2 sources where we receive organs for transplant. One is the cadaveric donor, and the other ones are the living donors. In the case of the cadaveric donors, these are patients that have encephalic death. This means not patients in coma, but patients that are not going to recover their brain functions, and the brainstem functions are involved and have an irreversible damage. And recently, some liver grafts can be obtained. Patients that have a cardiac or heart failure, the cadaveric donor system requires a national system that's going to be organized and regulated by the donation systems. It's also the most frequent alternatives, and most of the organs around the world are transplanted from a single donor, a cadaver. It allows to transplant all solid organs, and it has a big advantage, and is that I can obtain multiple organs from a single donor. Most importantly, the regulations of the cadaveric donors are based in the distribution of organs. With respect to those organs that come from living donors, these organs is mandatory of all the world programs via donate healthy, voluntary, and altruistic donors to have it available for a sick person. In the case of Colombia, we accept the 4th consanguinity siblings. This is an alternative that raises and emerges initially as part of the medical practice, and now it has been established thanks to the availability of the cadaveric donors. Who can we do, and who are the ones, what organs we can obtain from a living donor? Basically, those paired or divisible organs, such as kidneys, that we know we have two kidneys, liver, that we can split it in two, we can divide it in two. In some places, the living donor of lung, especially for children, pancreas and intestine, among others. There are places around the world that we can obtain intestine. These are the most important organs that can be obtained of a living donor. And the most important regulations, the, I would not say limitations, but rules or norms and standards to have from a living donors are basically the ethical regulations. This is why I'm emphasizing that it has to be a voluntary and altruistic system, and hopefully between families and parents. What are the advantages of the cadaveric donors? Well, we are not risking any person. We all know that any medical situation requires a risk for the patient. Therefore, if we are going to obtain a living donor, this implies that we will be somehow risking the patient to this donor. We also have a greater availability in cadaveric donors. Spain had a donor rate of 34 donors per million until the implementation of the cadaveric donor stop heart. It increased this rate in 50 per 1 million, and the rates of living donors, the rate transplant rates with living donors are reduced around the world. Is like that. Generally speaking, we can have complete vital organs with cadaveric donors, not divided as in the liver. And donation and donor rate depends on the population. In the case of the living donor, we have some advantages. One is the shorter waiting time, given the case that the time in which this transplant will be defined depends on the feasibility of that donor. Generally speaking, this is a donor that has not passed by a traumatic condition. And I'm referring to a traumatic is to a death process. Therefore, this is a healthy patient that due to the fact which is a scheduled, programmed surgery that ischemic time, which is the organ not connected to the body, is less, and it can be assessed easier, the compatibility. So there will be not only the immunological part, but also in children, relationship between weight and height of the organ, less cold ischemia as well. Some publications have said that the results of living donors are higher with respect to the cadaveric donors for the reasons that I just explained about compatibility. This is a surgery, is elective, although we can also do it in an emergency case. In those cases, the children have an acute failure of the liver when this is not working anymore. We have done this procedure, even the donor studies and the receptor, 8 hours when we have that patient in the emergency room. And definitely this is an option where there's a low availability, or like in many countries where due to the fact to um, infrastructure development and medical technology, we still don't, uh, there's no medical advancements. So as every procedure, there are also some disadvantages in the cadaveric donor. These are patients that require a waiting list. Normally, the organs distribution in waiting list to those patients is done in accordance to the severity of the organ in case of vital organs, and also to the immunological compatibility and blood uh, in those cases, this can be limited, or organ state conditions may be borderline because many these patients are really sick patients. It can be discussable, this use, although in some cases this is a need due to the same emergency condition. And also there are some specific regulations in cases of those patients that are abroad patients, given the fact that in almost all of the world countries, The organs distribution for national patients are preference to national patients of each country. With respect to the living donor, the most important disadvantage that we have is that it implies a risk for the donor patient. There are limitations, as we saw previously, with respect to the type of organs that can be transplanted. For the health system, it implies a higher cost, and this higher cost is not an arbitrary decision of the medical staff of the health institutions, but this is based in a high technical complexity. And this is the reason why the living donor programs are not so spread around the world, but it's limited only to some high complexity institutions. With respect to the indications, a fast look and overall look. In the case of kidneys, we need to consider this is an end stage chronic renal failure. So the organ is not able to support the vital functions of the patient that will be suffering from this disease. In the case of the kidney, we are talking about the end stage chronic renal failure. Patients that are receiving dialysis should have some assessment that is addressed and aiming to look for an organ transplantation. It has been seen, and there are clinical trials with the dozens of patients where it has been demonstrated that populations with dialysis imply a higher cost for the system. And apart from this, compared to the transplant, and also a less survival rate, given the heart complications of these people, that these people have. Also, patients that are pre-dialysis patients, also in children, they are potential candidates for kidney transplantation. And of course, it will depend on an estimation that can be done with images in nuclear medicine and only some test with the glomerular filtration rate. In the case of the liver, we always talk about patients that have an acute or chronic liver failure, which is irreversible. Some liver tumors, such as the liver carcinoma and some neuroendocrine tumors, even some metastases that can be considered for transplantation. And a question that is frequently done: I have cirrhosis. Am I candidate for transplant? And it is important to clarify that not all the people that suffer from cirrhosis are candidates for transplant. Only people that have had complications are candidates for this type of procedures. Let's remember that these are highly complex procedures and have a mortality rate where risk of having cirrhosis is higher to die at that time. This patient becomes as a candidate for liver transplant, and the treating physician is making some tests and estimations with the clinical condition of the patient, and will be deciding whether the patient will be candidate. Why am I only talking of liver and kidney? Because these are the most organs that are transplanted, are the organs that can be transplanted with a living donor. What cares do I need to have? A pre-transplant care. Important to maintain regular medical checkups because I'm a chronic patient and need to assist periodically to check up in order to be transplanted and avoid any decompensation. We need to follow those medical recommendations, also to maintain regular physical activity, of course, under the medical supervision, and also keeping good nutrition, optimizing proper nutrition, because there are some clinical trials that have demonstrated that the mortality risk in liver transplantation increases when the patients are really depleted with nutrition. This is known as sarcopenia. It is important to have support from family and loved ones. This network is important for all the procedure, not only before, but after the transplant. Also, always to resolve all doubts with the treating physician about the process, because I was saying before, when we are doing the assessment, maybe I'm receiving dialysis and I ask myself why my treating physician has not assessed me for a transplant. Maybe there's a contraindication, which is important in order for me to be taken and receive a transplant. So it is important basically to resolve all doubts that we raise with the treating physician. When we already have in that waiting list, for example, it's important to notify the responsible medical staff, many time nurses or our treating physician about any eventualities that can search if I'm in the waiting list for this organ, and also always be attentive to the call, avoiding long transportation during this waiting list, because we have seen that many patients that are in a waiting list for 1 year, some of them are for 1 day, 24 hours, and due to that fate, the destiny, the organ comes before you are thinking. So what is the goal of the transplant? Goals of transplantation, as the WHO says, is to prolong the patient's life, but always thinking in the quality. And I can tell you that patients' life quality, generally speaking, improves relevantly if a patient is on dialysis 3 days a week. With a satisfactory result will come out of dialysis, and this will be recovering the autonomy and the patient's and quality life. What does this mean? This means that patients that will be transplanted should get back to their life, practically normal life. They reintegrate into a normal life. So academic and labor work activity. And this will make them to participate actively in the society is one of the important goals. Of course, to reduce the number of complications related to their pathologies, reduce hospitalizations, and therefore, in the case of the kidneys, as I was said before, to reduce the cardiovascular risk as well. What do people have to know when they take care of the transplant? The first thing is to avoid all the complications that come from, first of all, the organ, which is not, and also to avoid all complications related to the medicines I need to take. And first of all, avoid organ rejection. And for this, as physicians, we do the prescription of an adequate immunosuppression and address to each patient, despite the fact that there are protocols that the immunosuppressions and drugs are tailor adjusted as to speak, but this is not only in the prescription, but also about that how that prescription is being taken. In our health systems, it depends on the delivery and administration of drugs of the health provider services, but in other places, it is important to have enough resources to have those drugs in case there's no insurance company that will be providing them. Also to avoid infection, important self-care. It is important the use of masks in situations when we have agglomerations, crowded spaces. It doesn't mean that a transplanted patient cannot go to the movies or concerts or perform sports and exercise, but all of this can be done, but the patient needs to be careful. Water has to be bottled water. The patient needs to avoid foods in restaurants or reheat it. These are things that are somehow common sense, but this care should be reinforced in order to avoid infections or to avoid any type of disease that are not desirable. And of course, new diseases must be avoided related to immunosuppression. And we are talking about some tumors that can appear related to immunosuppression. Also, there's some cardiovascular risk that increases. So I was emphasizing the nutritional part because immunosuppression, obesity increases cardiovascular risk. And also, we need to be careful with kidneys. This makes part of the medical follow-up that we do during the controls of this post-transplantation. With respect about cares after transplant, always following medical and nursing recommendations, taking medications judiciously, following schedules. Also, those immunosuppression drugs, there are some drugs that have to be taken before meals, other that have to be taken after meals, protection with infections. One of the most important things is not smoking, and this is an implicit smoking because smoking favors vascular thrombosis. So this is important to ban and avoid smoking. Also, progressive exercise and regular physical activity. Maintain support communication with the team. There are some networks of transplanted patients that are of great support for their families. Try the school and work reintegration, and as I was saying, to maintain self-care at all times. Transplantation begins a new life. This was a patient I transplanted 11 years ago with a living donor, and the donor was his mom. She's a psychologist in a health institution. And here you can see the picture of Manuel before the transplantation, before, after the transplant, hospitalization, and 11 years after climbing to the Paine Mountains in Chile. For you to know, this is for you to know that patients with transplantation can continue their normal activities with no restrictions. It is simply increasing their care, but definitely they can begin a new life. Tatiana, the person you are seeing here in this picture showing her medal, just participated and won 3 medals in the World Transplanted Championships and races. This is a competition where more than 1,000 patients that have been transplanted participate in more than 16 sports modalities. And she is a triathlon champion, not a chest. She's a triathlon champion. So this is one more way to show you that patients can perform any activity. And in the lower part, you can see another patient of mine that was transplanted, but was in a very bad conditions, health conditions before and after the transplant. And despite the physical limitation, he does not have a leg. He participates in sports and recreational activities, even as competitions. In order, the take-home messages, organ donation save lives. So in your countries, you have organ transplant, please become donors. Help this with your families, with your siblings. This is our responsibility, those who are us to work, who work always to promote and encourage organ donation. Always important that this care is shared. It's not only the responsibility of the physician or the nurse. This transplantation is just the beginning of the life patient, and it does not define the life patient. It's only a small part. Then care has to be individual. This is only the beginning of a new life, as I was saying. This is not a limitation anyway. And with so low cadaveric donation, living donor transplantation is an excellent option for those patients that don't have the possibility to access to a cadaveric donation. So, okay, thank you so much for your attention, and I am attentive to respond to any question you may have. Okay, first of all, thank you so much for your talk. This has been really interesting. Well, since I'm hosting these lectures, I really learn a lot. Well, I'm going to share with you some questions from our audience, maybe some question of my own when I have listened to you. Okay, first of all, how is it possible of a living donor, liver living donor? If a living person can live without a liver, can you explain this out, please? Yes, as I was saying before, as I was sharing you before in the talk, this living donor transplant can be done in patients and livers and organs that can be divided or that can be, but in the case of the liver, this is wisdom part of the nature, because then we can divide the liver and we can decide the size of the parts that we can obtain. What does this mean? This means that, for example, for children less than 5 kilograms, we don't have any constraints for liver. due to the weight, less than 5 kilograms, we have a small part of the liver, of the left part of the liver, keeping all vasculature where we receive the blood supply. This allows the liver to be alive. For children more than 25 kilograms, we have like 15% of that liver. And this can be done in an anatomical division and totally functional without implying any important consequences for the living donor. For patients more than 45 kilograms, we have 40% of that liver. And for donors more than 45 kilograms, we need to have 60% of that living donor. And this is more complexity surgery, as we are saying. We doing this procedure since 2017, and we have more than 100 cases in our institution. The organ has two things. One is the regeneration potential. And this means that whenever a part of my liver is removed, let's say an important volume of the liver grows as the matter of a need of my organism, of my body. And the other thing is that a healthy liver can live, we can remove 60% of its liver without being a risk for this healthy patient. Well, of the loss of the native organ. What, this is a good question. What would be the most important risks for a living donor? In the case for kidneys, there's always an implicit risk of renal failure in the donor. However, there are studies that have demonstrated that the donors have a more survival rate, even better kidney function than the common people. And this happens because these are people that are really concerned by keeping their health condition and have them improved, and they are better cared by the physicians to the donor condition. However, there's always a risk because let's say that the renal function of this patient, basically, we will reducing it to 50%. And the kidney does not have this advantage compared to the liver. Well, talking about kidney, during surgery, and this applies to both surgeries, there's always a risk. There's a bleeding risk. The surgery can be done with laparoscopy. Here, with respect to the technique, and this is part of the potential complications, we need to identify really well all vessels. We need to clip and the closure of these venous structures, and eventually we could have a bleeding here. But this is a highly rare complication that fortunately does not occur. The same thing happens with the liver donors. As you all know, liver is a solid organ, it's a gland, the biggest gland in the body. Dividing it is a structure that it is richly vascularized. So this is a loss of blood, but this is done with really advanced technical surgeries, and this prevents transfusion. For example, more than transfusion, need the voice importantly requires transfusion. Of the 300 patients that have been donors, unfortunately, anyone has needed hemocomponents transfusion due to the fact, because this is a surgery that it's really planned. Well as to the receptor, the deceased person, these assessments are done to see if they are candidates for transplant or if there's any contraindication. The same thing is done with the donor person. To the donor patient, we make a complete assessment for 3 days because the risks for donors are not only physical, but also psychological risks. And they are in a stressful condition, seeing their family or parents deceased, and we make a complete assessment, internal medicine, mental health, social work, and this is almost like a medical checkup where we determine if the patient is within the good conditions, which not implies a risk for their condition, and that their organ will be validated to be placed in the ill person. Excellent, excellent. Okay, there's another question. Two more questions. How long the transplanted patient has to be immunosuppressed? Is this temporary or a long-term immunosuppression? And the transplanted person is uh, life, yeah, for life. It's for their life, yeah. And the reason for this is that that tissue, it seems, it's nice to say this is like a loaned organ. It was done, is yeah. So its genetic brand, its footprint is different than mine. So for this reason, I am going to identify this organ as a strange organ and the trend of, and this is borrowed, and my organism will be attacking this organ that is borrowed. So after some years, after the second or third year to be transplanted, they are feeling well, stop taking their drugs and medications, and we start presenting rejections. So it is important to know that all drugs and medications, specifically with immunosuppressions, are for life. Yeah, are for life. And there's a question of all the organs that you mentioned, are studies been done to make other places different than the ones you have mentioned, advancements around other organs? Yes, yes. Many things has been done. We have a lot. We have news also. In France, the first transplants was done in face, in arms, in people, more than organs. These are tissues, but these are multiple tissues because this implies skin, bone, muscles, transplantation, and nervous structures. So let's say that yes. But basically, those organs, the tissues that can be transplanted are bone marrow that are not solid organs, and also skin, cornea, bone. This is generally in tissues, talking about tissues, and in some organ cases, okay, cornea, yeah, heart, lungs. In Colombia, many years ago, I don't quite well, but trachea also, some years ago, lung also, liver, intestine, multivisceral transplant in some patients that have intestinal failure. And as I was saying, the kidneys, but really the limitations, the most important limitation, for example, in the case for nervous tissues, hands, legs, even there has been there has been some news about transplanting eyes or head. The most important is the neurological reconstruction. Given that neurological activity makes it mm, impossible for some organs to be transplanted. Okay, perfect. Well, listening about skin, but can you is an animal transplant can be transplanted to a human being? I have heard. I don't. There's another organ. Yes. No. Now, no. Currently, thanks to the genetical engineering, there it has been one of the most important advancements. 1 year ago, in the United States, a patient that offered as a volunteer to receive a transplant from a different species, and this was a pig that was genetically modified. The patient was transplanted, but he died due to complications associated to some months ago, some months after. This is an ongoing research, but thanks to genetic in medicine, those that work on this, those these brands, these genetic brands, thanks to the genetic engineering, we need to eliminate it in order to address any other tissue. There are advancements in research, but we don't have a reality yet. Okay, perfect. Adverse events of patients with immunosuppression drugs, many adverse events. When we see, we have like two adverse events. First, we read them with side effects. The most important side effects that can happen are increase of infections, as I was saying. It also can increase the malignity risk, especially in those organs that need and require more immunosuppression. Also, kidney failure, skin cancer can also increase this immunosuppression. So there's a sun protection and sunscreen, physical screen of long shirts and the most sun exposures, importantly. These are like some side effects that are the most important. Okay, you mentioned something about reheated meals. I would like to go deeper. Yes, yes. Um, the issue about reheated meals is basically the bacterial proliferation and food manipulation. When we want to avoid gastrointestinal infections, first of all, we need to know where the food comes from, how they were manipulated, and do them as careful as possible. What we recommend to our patients is preferably in most of the cases to do those meals, cook those meals at home, because you can know how you're manipulating food. So really washing food, well cooked food. That we all also we know that some food such as chicken, when it has been overcooked for a long time, it can increase the staphylococcus production, which is toxic, and this can produce poisoning or intoxication. So this type of behaviors that are common in our lives, in livelihood, we need to reduce things as maximum as we can. Is like last night meal and then the next morning I want to eat something about this. Well, it's not a big issue like the turkey Christmas Eve dinner, but we need to try and avoid most of all that many people can have contact with this food and meals, but all the appliances to be really clean and inadequate manipulations of these appliances. This will avoid to have issues, especially gastrointestinal infections. Well, I would like to make a question, doctor, that is turning around in my head. But I'm thinking, are there early markers in labs or any new technology that will predict that rejection? For example, we are at home. What could alert us to our parent, to our family member, and what would indicate a rejection? Yes, in technology, we have had some advancements as well, some studies that pretend to identify some markers, for example, in urine markers to see if the patient has a rejection, but they are not commercially available yet. It is important, and this is the reason why it is important to do a medical follow-up. Most of the times that we have a rejection of an organ, first of all, generally speaking, this is like a flu. It's like this has, generally speaking, this is a flu, an organ flu that responds to a pharmacological. And most of these rejections are subclinical. This means that they don't present clinical symptoms in most of the cases. Therefore, they will be identified by lab tests that have to be done for these checkups. And this is important, the periodicity of the consultations. And on the other hand, this is where we see the importance of having all medications to be taken. Because as I'm not feeling anything, the trend is my trend is going to be if I'm not feeling anything, I'm not needing anything, and I'm not taking my meds. And what we are seeing, not in the next consultations, but in 2 or 3 consultations after, we will see important changes in the biochemical on lab tests and the rejections that many times is very difficult to treat. Okay, doctor. Okay. On the previous question about meals, we have a question that meals that are prepared at home, that I'm freezing that food. Is there's a risk? Not. No. Freeze food does not have any problem. Frozen food, no, there's problem. Also, yes. In except research studies, we should keep immunosuppression, despite the fact that maybe that the first transplant, I did not name it here, but was done with identical twins, and it had a long duration because there was a genetic compatibility almost 100%. It's groups of patients, we always keep immunosuppression. Really careful. How advanced? I don't know, but how advanced is medicine with respect to synthetic organs? Yes, strongly it is being worked, strongly being worked because the deficit of donors is on a global basis. Well, first of all, it requires a high technology that only some centers can offer, not even countries, but some centers specifically have access. And secondly, the cost. These are highly expensive. But yes, from here, in 10 years ahead of us, we will have strong advancements about this. Okay, to start closing, this is a question that I know there's not an answer. I imagine that is for each specific case, but there's an estimate on when we can, the moment we can give discharge that patient. Do you say hospital discharge? Yes, hospital discharge. Depends. It depends. In longer transplants, the stay in the hospital can be 1 month, 2 months during that hospitalization. And with my children that have been transplanted by donors, living donors, this is like 10 to 15 days, which is similar to another patient with this stay. A patient with renal kidney transplant, 6, 8 days can be discharged and be sent home. Yes, perfect. And the donor, on the other hand, the donor patient, the living donors of livers, in the case of livers for children, the stay are 2.5 days. Of an adult donor, the stay will be 5 and 8 days, and for kidneys, 3 days as well. Now that you mentioned this, they are immunosuppressed until how long? They have to be immunosuppressed, the donor's patient. No, the donor patient does not need any immunosuppression. And this is also important, very important to have done, because those donors, the donor's life must not change with that organ donor. If you think that the life will change, that patient should not be a candidate for donors. Yes, this is why the evaluation has to be done. The idea is for this patient to be done and no need for medication, and the life risk by being a living donor will be practically zero. Yes, practically zero. This is the idea. Basically, the risk of a surgery, any kind of surgery, yes, exactly. As when we are operated by the uh, vesicle and my gallbladder has been operated, this is exactly the same idea with my appendix or gallbladder. Yes, it's that same risk for a donor patient. The donor patient must not be operated. It's absolutely volunteer. Okay. I'm going to make this last question. You mentioned some tissues and initiatives that are being done. Okay, colon transplant. Is it considered? Is it been approved? Is it tested? No. Colon? No. Because this colon transplant is done for intestinal failure. What does this mean? Those patients with intestinal failure are those patients that eat And basically, they don't have anatomically or functionally, that intestine is not able to absorb any type of nutrients of everything the patient eats. So here we have some nutritional standards that define intestinal failures and anatomical as well, because there are images and studies that are being performed to see that length of the intestine. We're talking about intestinal failure. We are talking about patients that have 30 centimeters of intestine, patients that are really short intestines. The colon compared to all the intestine is a proportion which is really small and relevant, of course, but let's say only for colon, we are not thinking about a colon transplant, no. Okay, perfect. There are many other questions left. And I want to thank you all. We have tried to respond to all of the questions or most of the questions. Okay, an additional question, but to end and to wrap up. Surgeries are always by laparoscopy or it depends? Also by donor, also by receptor. It depends. It depends. Well, it has its pros and cons as well, but in the case for liver surgeries, the surgery that I do, the kidney surgery, 99.9%, we are doing it by laparoscopy. With liver, when it's for children, 99%, I will do it an open surgery. And the reason is a preference. The OR time of open surgery are for 2 hours versus 6, 8 hours that can last a surgical time with laparoscopy. And the aesthetical outcome is practically the same because the incision is this size, this big for the donor patient. And in the case for laparoscopy, it's the same, only that it's done in another place. And the hospital stay is highly low, 2 days of stay. So if we are talking about benefits for the donor, this can be discussable, but this is also as a with a preference that there are two variables. One is the donor preference, and the other one, of course, we will be discussing it during the meeting with respect to the potential complications that can be higher with a laparoscopy surgery. Okay, perfect. Well, first of all, we want to thank you again for your participation today. For all the audience, in this screen, you also have a QR code where you can make suggestions, recommendations about the organizations for today. We want to thank you all. We want to know your opinion. I have this take-home message about the donor, and we need to promote and encourage around all countries. This is important, not only to the private case, but also for the public. Yes, living donor transplantation is an excellent option. Yes. Well, thank you so much for your talk. This has been really interesting. As you know, there have been many questions, and we have a lot of questions also that are not addressed. On my part, I want to thank you. I want to thank Carolina, Sura, of course, for this partnership that we have. And this is only an example we have of this alliance that we are having some months ago. Thank you, La Cardio. Thanks to the participation of Dr. Jairo. Carolina, do you want to have some closing words? I want to thank you, Dr. Jairo. Excellent talk, as Miguel is saying. It is an honor to participate in this space because a lot of learnings from today. Thank you for your time and thank you for providing knowledge with all of us. And thank you all for being here, for participating. And it is a real pleasure for us, this alliance, this partnership, and the idea and the aim is to potentialize it more and more every day. Okay, Dr. Jairo, do you want to close? Okay, it's an honor for me as well. Thank you all. And hopefully you enjoyed this lecture. Okay, you can send all questions, all the La Cardio. You have any questions, any concerns? We will try to respond you as soon as possible to all to your inquiries. And really, it is highly interesting for us to let you know what we do. For us, it's an honor to be part of this network. We've been working with Suda for many years, and we are excellent partners. This is excellent, the relationship that we are having with VUMI. Okay, we invite you all to visit our blog as well in VUMI group. And well, I want to invite you all. During September, we will be having another VUMI Health Talk. So please be well and see you soon, shortly. Bye.